Ugh, headaches suck. I can tell you that because I've been suffering for a headache for the past couple days. I don't know what it is. Maybe I could blame it on COVID. Actually, I don't think I have COVID as a side note, but I have had a headache and it.
I'm Dr. Bates, and this is Musculoskeletal Minute.
But, anyways, headaches suck. You can't really concentrate, focus. Really, you don't want to do anything due to the aching, pounding sensation in your head. And headaches can impact anyone, including myself, over the past couple days. And honestly, personally, when that happens, it's more than likely my own fault, either due to poor sleep, dehydration, or I've been sitting working on a computer way too much, which is likely my problem this time. However, my pains are minimal in comparison to others. I have seen patients suffering from debilitating headaches that interrupt life, not just occasionally, but on a daily basis. In keeping with my goal to keep things useful, let's start with the most common types of headache, along with good techniques to help that. We will be covering the features of tension headaches, along with the exam and workup, and differentials, and then the most important part, how to treat. Tension headaches are the most common type of headache suffered, and they're actually the second most common medical condition in the entire world, only being beat out by dental caries for global disease burden. So, number one, cavities. Number two, tension type headaches. Number three, migraine headaches. So basically, headaches have a massive burden across the entire world, and most of you and most of your patients will suffer some headaches. Interestingly, with tension headaches being number two most prevalent disease in the entire world, they're also the least studied form of headache. That's probably because they're also kind of just common. Tension type headaches are stereotypically described as bilateral non-throbbing headaches without other associated features. But just like all things in medicine, they can totally be unilateral and throbbing at times with other interesting features. Other descriptions, though, have included dull, pressure, head fullness, head feels large, or more descriptively like a tight cap, band-like, or a heavy weight on my head or shoulders. Triggers for tension headaches include stress and mental tension, along with head and neck movement. And unfortunately, they can be commonly associated with migraines, one feeding from the other. Some people, the tension headache will start the migraine, and in other people, the migraine will start the tension headache. However, to differentiate between a tension and a migraine, symptoms such as nausea, vomiting, photophobia, and phonophobia are more likely to be associated with migraines than they are to be an tension headache. However, they are not fully exclusive. Though, auras and other neurologic changes such as numbness, weakness, loss of coordination are much more associated with migraines. So if we're working this up, really you do not need to get imaging for a tension type headache, unless there's a couple concerning features such as a sudden onset thunderclap headache and it's the worst headache of my life. Those get imaging for, stat. Other things such as new neurologic findings, an abnormal headache, and also a headache during pregnancy, which is new and abnormal. Those all are indications for further imaging. Make sure you do a cranial nerve exam and cervical spine exam. Go ahead, check out my YouTube channel. I actually break down both the cranial nerve exam and cervical spine exam into useful exams that you can do in less than 2 minutes each. Those can help determine imaging. If you have positive findings on one of those exams, you probably should think about getting some imaging. If you are going to be getting imaging, a non-contrast CT is what you should get for emergent situations. However, they don't yield a lot for diagnostic workup outside of emergent ruling out any sort of brain bleeds. For that, you want to get a non-contrast MRI. They're much higher resolution and can show much more of the pathology that we're looking for in our differential. On physical exam, you'll find tight cervical paraspinal muscles as you palpate the occiput and down the center of the spine and into the shoulders. Trigger points are very common in the trapezius muscles, sternocleidomastoid, and temporalis. Other findings include decreased range of motion. As in all of medicine, let's remember to have a good differential. For tension type headaches, of course, there's the tension versus migraine headache, cluster headache. But what about some of the other types of headaches? Medication rebound headaches. These are usually episodic migraines or tension headaches that have been treated with just a little too much medications, and you come off of those and people get a rebound headache. Wean off the meds for those. Cervicogenic headaches usually come from the neck, and what differentiates those from your stereotypical tension type headache is that the pain is usually unilateral. Again, utilize a good physical exam to help you with the differentiation of this. Also, keep in mind stuff like a sinus headache or even brain tumors. Keep an eye out for anything that just isn't quite normal. So, how do we treat tension type headaches? I mean, they are the #2 most common disease in all of the world. What do we have to treat them? Well, actually, ibuprofen and aspirin are the best go-to medications. Tylenol can be used, but it doesn't appear to be quite as effective as either ibuprofen or aspirin. Treatment success for headaches is based off of a 2-hour pain-free time after taking medications. For ibuprofen and aspirin, while they are good first-line treatment, it's still less than 50% of patients experience relief still at the 2-hour mark. So if those medications aren't working, combinations with caffeine tend to bump up the results and tend to work quite well. And they still continue to have a decreased risk of addiction, rebound headaches, and other systemic side effects. Some people have gotten a little bit creative putting other medications in with the ibuprofen, aspirin, Tylenol, caffeine mixes. However, those additional mix-ins actually have found to increase rebound headaches and actually don't have as good or do not have significantly greater results of reducing pain than just the combination of caffeine along with one of those other medications. Other meds that do not work well and have higher side effect profiles include opioids, muscle relaxers, and triptans. So what about not using medications? What do we have here? Well, let's keep in mind the overwhelming power of the mind. A well-rounded treatment of headaches can include behavioral therapies such as cognitive behavioral therapy, biofeedback, along with self-management and education. A lot of these focus on identifying triggers and working to remove them or live with some of those triggers. Some of these triggers are simple items that would help all of us, ourselves included here. And number one with that is prioritizing sleep, managing stress, ensuring good diet and exercise, and also education about the condition and about the good treatment of the condition, such as not overusing medications and wise management of caffeine, both in your daily intake and then also the treatment intake. Again, all of those could benefit all of us, but it's much easier said than actually done. Acupuncture can be helpful. Unfortunately, studying acupuncture has been extremely difficult, and I will be talking in some near future point philosophically about acupuncture. It's actually quite interesting. And apparently there's a difference on where you get the sham acupuncture with how effective it is. It's really interesting. Stay tuned, keep an eye out for that one. But anyways, I digress. My personal opinion here is if you have acupuncture available, it might help. And if the patient's not getting better with medications or other treatments, I don't really see much of a reason that it would hurt to give it a try. If it works, awesome. If it doesn't, well, then you know. Physical therapy can be useful for the treatment of headaches, especially in the prevention of future episodes of tension-type headaches. However, the literature on this shows that it can help and also questions whether or not it really does help. But again, kind of like acupuncture, physical therapy is quite difficult to test and study. One of the big reasons why physical therapy is so difficult to test is the fact that physical therapy encompasses so many different things. Some physical therapists love utilizing modalities. Some really like utilizing exercise. Some stick to massage. Others utilize electrical stimulation and ultrasound. Some physical therapists absolutely love posture, especially when it comes to head and neck pain. And others say that posture is just a giant myth that is perpetuated. So that makes it really difficult to study to say, yes, physical therapy does help. Let's face it. Studying whether or not physical therapy is useful is kind of like saying, is cardiology a useful medical specialty? I don't think anybody would study that because we have interventional cardiologists, electrophysiologists, and those guys are brilliant. They can tell you anything about a patient just by looking at their EKG, to heart failure specialists, to your run of the mill cardiologist. I mean, it's way too big of a field to study. Nobody is saying the electrophysiologist didn't do a great job on treating the heart failure. When we have heart failure specialists, well, we aren't discounting an entire medical specialty of cardiology just because subspecialists within that field have better outcomes than others. Anyways, I digress. Physical therapy definitely can help. Give it a shot. Um, and I'll be going down that rabbit hole about how certain things are studied within musculoskeletal medicine in a future time. Obviously, there's some great material for that, and I keep getting distracted on this one. So, back to the point. What else can we do to treat headaches? Well, we can do some OMT, or we can stick a needle in it. Personally, I like doing a little bit of both, starting with some OMT, but if things just aren't getting better and helping the patient out, then it comes a great time to stab somebody. I mean, do injections. There is one technique within osteopathic medicine that I think is absolutely fantastic for headaches. It's called the suboccipital release. I love it so much. I use it pretty much anytime any of my patients have any sort of headache or neck pain. It's really easy to do, and it pretty much makes anybody feel better. It is direct pressure of your fingers over the occiput. The direct pressure provides an inhibition to the semispinalis muscles, which are generally quite tender and angry as they have to hold up your entire head. But that pressure helps decrease their overall hypertonicity, and that relaxes around the greater occipital nerve, which passes straight through those muscles. So, since it passes straight through the hypertonic muscles, they're probably clamping down on that nerve, causing the nerve to fire. And what does that nerve innervate? Well, it innervates the whole posterior aspect of the scalp. So, you start right there, very hypertonic muscles with a nerve keeps firing because the muscle squeezing down on it, it feels like the entire posterior scalp goes, and it just continues to feed into itself, making things worse. So treat that with a little bit of suboccipital release, and your patients are going to love you. Check out my YouTube, Musculoskeletal Minute. I have a video about the suboccipital release posted there. Other videos are coming about cervical spine stretching, along with some other techniques that are also great for relieving stress along there. Um, Another technique that I use, I don't use it quite 100% as consistent as I use the suboccipital release because, as I said, suboccipital release is absolute gold. I utilize the body language that the patient displays and shows me about where their head hurts and if there is extra pain and tension in their necks leading to that. And then I utilize the fascial distortion model to evaluate what that body language means and then treat it accordingly. One thing that I love about this technique is that you treat what the patient indicates. The patient is the expert of their pain. They know what they're feeling. We don't know. So we follow exactly what they point out and we treat it accordingly. This will be discussed more in future. I actually hope to have some of the gurus of this technique on, as it is just such a powerful technique and it can be applied to all parts of the body. But I find a really good success with both the head and neck for this. Other techniques involve stretching, muscle energy to relax the muscles, and of course, trigger point manual therapy. And, well, if the trigger point manual therapy is not working, how about a little bit of trigger point injections? Go ahead and inject some fluid into the trigger points and basically uses the pressure inside of there to perform a hydrodissection, help basically expand the trigger point and allow the body to remodel itself appropriately at that point. Studies have shown that it doesn't really matter what you inject, whether it's saline or lidocaine or a mix. They have found that Botox doesn't provide any additional benefit in comparison to those, so don't waste your money on the Botox, save that for other areas. And steroids don't need to be injected in trigger point injections. I prefer to use just lidocaine because, hey, you're going to inject that area, you might as well numb it up and give the patients a little bit more comfort. It's not the numbing that does the treatment, it's the hydrodissection that does the treatment. One of the big things, though, to keep in mind with trigger point injections is know your anatomy and don't stab anything important. So, trigger point injection therapy has been studied in the neck and it has been found to be quite beneficial. I do want to note that with part of our treatment, we do need to remember that there is a sensitization aspect in tension headaches, which lead to altered nociception and possible habitization in some patients. So, this is where I think it's important to treat the pain with multiple modalities. Medications are great, medications provide a quick, easy benefit, but it's also good to consider physical therapy, acupuncture, OMT, trigger point injections, all of those to help break this cycle so that our patients don't continue to lead to an increased nociception and habitization of the nerves and kind of keep feeding into this path. Part of what we want to do is try to break this path. So I encourage you, yes, it's really easy to say, hey, put the lime in the coconut, call me in the morning, but doing some of these interventions can hopefully help prevent the headaches from becoming a recurring problem. Keep this in mind over the coming week. Use a good physical exam to accurately diagnose a tension headache. Try some of these techniques to treat them. Check out my YouTube channel, Musculoskeletal Minute, for more instructions on how to use these techniques. And if you can properly identify a tension headache and treat it appropriately, your patients will experience pain relief now and probably in the future as we're decreasing some of that habitization. So please go ahead and subscribe to Musculoskeletal Minute on your favorite podcast app. Leave a review. This really helps with podcasts. I would love to hear from you about your success stories and also your questions and what you would like to learn. I do want to focus these things on what will be the most useful things in clinical practice. I don't want it to just be me rambling about things. I am pretty good at that. But I want it to be something that can be useful, can be taken and applied immediately the same day as you're listening to this. So please, I'd love to hear from you. And also go ahead and connect with me via social media on YouTube, Musculoskeletal Minute, Facebook, and Instagram. I'm on there on both of them as Musculoskeletal Minute. So thank you for joining me today, and I really hope that you can use this and apply it and help a patient this week.
Thank you for joining us on Musculoskeletal Minute. We have your back. Please remember that this is for education and does not constitute medical advice. Please subscribe, leave us a positive review, and share with your friends.